Thank you very much, Dr. Ramamurthy, and really for a course on femto, which I think is very much worth learning about and looking at. I appreciate your willingness to share sort of some of the controversy, and I think that's what I really will do today. So my financial interest, I actually am a consultant for two companies, and it was as a consultant for LENSAR. I believe I was the second American surgeon to actually use the femtosecond laser, and this was in 2009 in Mexico City. So this is what many people have considered, that this might in fact be the future. And I think if it is to be a paradigm shift, that's really the question that I'm often asked to speak about. Do we buy it now? Do we buy it later? Will we ever need it? I think there's clearly an appeal for both patients and physicians. It's potentially safer, refractive benefits, and certainly high tech. And that's very important. But let's do this hypothetical. Let's say that something like this was a one-time purchase, $200,000 US, but there was no click fee. So you would buy it, you would decide who to use it, when. You wouldn't necessarily charge the patient for it, maybe, if so, just a little bit. That would be very different. I think we'd all rush out, and it would be like a surgical microscope. We get the best one, we have the instruments available. But the challenge is that this is not how it works. It's very expensive, and the patient has to pay for the cost. So this isn't necessarily the only way this could have been done. There could have been a monthly subscription like Aura with WaveTech. Or it could be a one-time purchase. But because it's a click fee, this really changes it, I think, quite a lot. We have to then say, sure, it's here to stay, but what's the advantage? What's the disadvantage? And will it be really affordable? And I think the question is, what percent of our patients will we end up using it on? I mean, just think back to the hoopla when the first presbyopia IOL came out. We thought this was going to revolutionize, be a game changer, and yet certainly here to stay. We'd say, okay, look, since 2004, since 1997, sure, there would be improvements in designs, but what is the percentage of multifocals that we're using now after 17 years? This is just the ASCRS recent survey, including our crystallins, and you see that most people are either none or 1 to 5%, few more under 10%. So the real average is about 7.2%. So the penetration, in contrast, monofocal monovision is about 3 times as high, even though there's a financial enormous difference in compensation. So I think that's the question for femto, is how many cases. There's certainly costs for the ASC. There's issues of the flow and the efficiency that we all know about in terms of it slowing us down. And really the cost is, how many cases do I have to do to pay for the overhead, which is the maintenance and the cost. And then I think it adds a whole other layer to what we talk about with patients, because now instead of just doing the steps the way we want, we have to get their approval and understanding of the extra cost for doing the femto. And sometimes that means doing marketing and advertising. Now, does that set higher expectations? And what about all the non-femto patients getting phaco foldable IOL that may feel shortchanged? So lots of concerns. Well, in this ASCRS clinical survey, 1,500 respondents, we asked 10 years from now, what will be your mix? Now, 2/3 said they believe they're going to be doing some femto surgery, but it's about equal between those that say it's going to be great, those that say it's not going to amount to much, and those that say they're simply not sure. This is 10 years down the road. So what are the benefits? Got to be something in terms of safety and refractive outcomes, and I think it's imperative our patients really are not asking us what's the most high-tech way to do it. They're saying what is the best, and that's where you have to help them evaluate it based on outcomes. Let's take another analogy. Let's say that someone came up with a femtosecond laser trabeculectomy technology. You could get a more precise scleral flap depth, a very consistent filtration window, and boy, you tell the patient, we can do your glaucoma surgery with laser. Wow, that sounds good. Well, hold it. None of us would really go forward with that. We'd want to see what are the outcomes. Does this help your IOP control? Does it prolong your IOP control? What are the outcomes? We wouldn't just buy in to the top 3 without knowing. And so that is really the question. So we asked in the survey, what are the clinical benefits? Of course, people said astigmatic keratotomy. People said capsulotomy. But a year ago, that these studies came out, this first from Australia, that showed that there was a higher rate of tears of the anterior capsule, not when you make the rhexis, but later on when you're doing INA, inserting the IOL, giving rise to the question, is the edge of the femtorhexis as strong as the manual rhexis? And these are scanning EMs that show that it is often irregular. In that same month, in the JCRS, we had a whole series of articles, again, one from Hong Kong, John Chang with the LENSAR, showing, again, an unusually unexpected high rate of late anterior capsular tears. And so that raised a big question. But this is the biggest study that we have so far. And I am indebted to Peter Berry, who presented this at the London ESCRS. So look at this. This is FLACS and ESCRS. Now what they did, if you look down this list, this is a who's who of some of the best European as well as Australian femto users. And they took these surgeons, 10 countries, and they got a consecutive 2,000 cases that they then put into the EUREQUO database. This is the ESCRS database that has more than 100,000 people in it now, patients, contributed from members. And they took that database and narrowed it down and got a 5,000 control group. So you got 2,000 consecutive femto against 5,000 manual phaco. Well, the age, as you might expect, the femto patients were younger, so that might be a benefit for that group. This is what was done. Interestingly, 2/3 of the time, the femto people were not using it for the incision, just for fragmentation of the rhexis. These are some of the femto complications, mostly capsule-related complications. But again, for the first time, we have a control group. So you're going to look at femto versus phaco. And remember, these are select femto surgeons, but they're consecutive cases. You had to report everything. Well, when you look at all of the major post-surgical complications that were already in the EUREQUO database for outcomes, there was no difference. No better, no worse. If you look at post-op surgical outcomes, actually the femto group did a little bit worse. Corneal edema, early PCO, and uveitis, a little worse in the femto group. This is 2,000 cases. If you look at BCVA, that's important, no difference. Well, what about refractive accuracy? How often were you within a half, within a diopter? No difference. What about surgically induced astigmatism from the more accurate incisions and so forth? No difference. So the conclusion was the femto group, they were younger patients, but there was no difference in terms of any of the outcomes, with the exception of a very slight increase in post-op complications in the femto group. And that is the largest data out there. That is the largest subset. So despite that, the outcomes basically were the same. So the barriers, at least in the United States, are certainly cost reimbursement, because our government does not allow us to bill extra for any of the steps that have to do with basic cataract surgery. We can only bill extra if we do something refractive, and so right now people are just adding this to the cost in the premium IOL. We cannot use it with a monofocal IOL. So when I go back to what it is that we and our patients really value, in the United States, we're not allowed to charge if it's safer or if it's high-tech. We can do it, we just can't charge the patient extra. And if you're looking at refractive then, which is the only thing that we're allowed to charge for, there are other things competing with the femto. We have a toric IOL. We have toric multifocals soon. We can do intraoperative aberrometry, and of course, we can also charge the patient and do LASIK afterwards to touch up their refractive result. What I think is really going to change is the light adjustable lens. The Calhoun Vision is a technology that is now finally finishing their FDA enrollment, which is 600 eyes. we're going to have this probably in 2 years. And we can adjust the cylinder and the sphere and get it just right post-operatively. I mean, these are published data on spheres. How would you like to have 100% of your patients 2025 uncorrected? Or take your LASIK patients, 30% of whom are 2025, do the adjustment and get them to 95%. Well, that technology is a reality. It's almost fully enrolled in the United States, where we can again do sphere and cylinder, and could be in 2 years that we would have that in the United States, and then when the FDA approves it worldwide. So at that point, the patient who has the money to spend on a refractive benefit, we're going to ask them, is it more important to have a precise capsulotomy or a precise refraction? And that, I think, is going to determine it. So in conclusion, I think there's a lot of controversy and certainly a lot more to happen, but really, unless I think it becomes faster, lower cost, or we get new government rulings, it will be there, but perhaps more for a minority of patients. Thank you very much.